y'all, it's your girl Ariza, licensed clinical social worker, test prep guru, your personal hype squad, whatever you need me to be to help you level up and pass this exam. For over the past decade, I have been helping test takers crush their exams and achieve their dreams. And now it's time for me to help you do the same thing. So this is your one-stop shop for your tools, your strategies, your confidence, all the stuff you need to level up, level up, level up, level up. Yes, so you can pass the exam. So today I got a banger for you. Yes, it is a banger. So I don't care if you're a repeat test taker, first time test taker, you here today, you gonna get some sauce. Today I'm gonna clarify some DSM-5 criteria from schizophrenia-related disorders all the way to the mood disorders. Sometimes they get all mixy and people get all confusey. So my job is to kind of help you compare and contrast some of these frequently confusing diagnoses. And I'm gonna give you some real vignettes, some diagnostic decision-making criteria and all that good stuff to make it a little bit easier and digestible so you can know what to do when you see these test questions, or better yet, you're about to be licensed. Even if you are licensed and you're watching this channel, because sometimes that does happen, we get a little, a little comfortable in our jobs and our careers and our professions. And sometimes as licensed individuals, we don't do anything clinical. But once you take that LCSW, you don't want it to go to waste, so you want to kind of keep your mind going. This type of training or this type of content is going to help those that are preparing for the test and those that have already tested. We're going to clarify the DSM-5 criteria for schizophrenia-related disorders, mood disorders. Again, we're going to go over some practice style questions, all that good stuff. But I'm going to jump right in and go ahead and hit you with the content, with the sauce, with the information that you need. Again, I did all that. Go get your pen, go get your paper. I'm going to give you a few seconds to go do that so you can go ahead and take your notes. I know, the over 40 crew, we love these things called note cards where we write everything on it. As you can see, I got little note cards and stuff all over the place. But anyways, you write down your information and your content, because today I'm not sharing my screen. I want you to focus. I want you to hear what I'm saying, understand it, and then you pause the video and write your note. Because I believe you can use these videos to help you elevate and pass this exam. However, it's a certain way you got to do it. You know me, I'm all about that strategy. Everything works. It just depends on how much you put into it and how you decide you're going to utilize it to make it work. So this video, yes, get your note cards, get your notebook, whatever you need to get so you can go ahead and start taking some notes. I am going to share my screen in the latter part when I do the questions, because I realize the real test, you're going to see the questions. So I want to do that for you guys. I want you to see the questions so you can kind of understand it and go from there. So that is why I play the R&B in the back, not so you guys can hear it, but it can remind me that this is time to be slow and relaxing so you guys can take it in. So for those of you that say I go a little fast sometimes, I hear you. I'm good, but I wouldn't say I'm perfect. So there are some things that I need to kind of work on. And that's one of the things. So I'm gonna calm down a little bit. So why does this training matter? Diagnoses like schizophrenia, bipolar 1, schizoaffective disorder, a lot of times they are misunderstood. And there's some consequences to that clinically, because if you misdiagnose, you often mistreat. Remember, you got to diagnose before you can treat. So if we are misdiagnosing someone, we can't be appropriately treating them, so that leads to mistreatment. Hopefully you're getting what I'm throwing at you. So when you're preparing for this exam, these diagnoses show up often, and sometimes they can be tricky. So the goal for this training is to provide you clinical clarity and confidence for when you take this exam. So get your pen and paper. These are the diagnoses we're going to go over today, so you want to take your little notes next to them. Number 1, we're going to go over schizophrenia. 2, we're going to go over schizoaffective disorder, bipolar and depressive types. We're going to go over bipolar 1 and bipolar 2, major depressive disorder with psychotic features, and brief psychotic disorder and schizophreniform. We're also going to go over delusional disorder and substance medication induced psychotic disorders. Yes, that is a lot. That I know it's a whole lot. It's 7 of them. So if you need to go ahead and pause the video, go ahead and do that. So that way we can go ahead and jump in. So we're going to start with number 1, schizophrenia. Let's break this thing down. So schizophrenia, you must have the following symptoms for at least 6 months. So 6 months or more. That's how we're going to look at it. You must have at least 2 in a certain, they have the core criteria. You have A, B, C, D, E. Yes, A, B, C, D, E. So if you're looking at your DSM and following along, this is probably great for you to do as well. And you'll notice that A, B, C, D, and E, they need at least least 2 or more of those 5 criteria. So you have delusions, you have hallucinations, you have disorganized speech, you have disorganized behavior or that catatonia, and the negative symptoms. So meaning if someone has schizophrenia, they have to have delusions and hallucinations, or that disorganized speech, negative symptoms, or the hallucinations and disorganized speech. They have to have at least 2 out of those first 3 criteria. Those are the 5 criteria, but delusions, hallucinations, and disorganized speech are the top 3, and they have to meet at least 2 out of those top 3. All right, guys, real quick, I'm always talking about the community, the LCSW vibes. We leveling up, and this is the sneak peek of the community. As you can see, it's on and popping. We got a lot happening. I got ethics over here, human development, or study guides that you guys asked me about on the YouTube channels, all right there. Test questions. You just want to level up and learn and see if you can answer those questions. I'm testing your knowledge. Let me go back to the home screen. If you want to learn more about what services I offer and what other things are there, that is where you go to the learning tabs. We leveling up, so why don't you join so you can level up too? So if someone comes to you and they're having some psychosis and you're talking to them and you realize they have hallucinations and delusions, they already met 2 of those top 3. Or maybe they have delusions and disorganized speech. They have 2 out of those top 3. Maybe they have delusions, hallucinations, and disorganized speech. All 3 of them bad boys. So therefore, those are the core symptoms and they're already showing that they meet those. So that way it lets you know, okay, yes, we could look and consider schizophrenia, especially if it's been what? 6 months or more. Absolutely. So another thing you want to consider here is functional decline in major areas, like they're having a hard time functioning at work and their relationships and settings of that sort. So let's break this down a little bit more. Let's talk about schizoaffective. Schizoaffective disorder has the same symptoms of schizophrenia, but this is a plus sign. So schizophrenia plus. Schizophrenia plus, yes, schizophrenia plus some type of mood disorder gives you schizoaffective. You gotta roll with me, guys, because this sometimes people get tricked up and they're like, oh, well, you know, they have schizophrenia, or oh, I think they're bipolar or psychotic. I'm breaking it down to tell you why this is this versus that. So with schizoaffective, they must have a major mood episode, like either manic or depressive. They must have delusions or hallucinations for at least 2 weeks or more without any mood symptoms. Yes, no mood symptoms there. They still have to have those delusions, hallucinations. So the key here that I like to tell people is that those psychotic features are still paramount in schizoaffective. That's how I can break it down and know the difference between someone having schizoaffective disorder and someone having bipolar. But we didn't get to bipolar yet, so let me stay on track. So the mood symptoms are present for majority of the illness. However, when there's no mood instability, the individual still has some of those delusions, hallucinations, or those other psychotic features. Now, there are some specifiers when it comes to schizoaffective disorder, and that is bipolar type. And you only give someone bipolar type if they have experienced mania. I understand there's 2 types of bipolar, but listen to me. We're not focusing on bipolar 1 and 2. We're talking about schizoaffective disorder and someone having bipolar type of schizoaffective disorder. Get me? So to say schizoaffective disorder, bipolar type. And if they have bipolar type, that means they have experienced some type of mania. Gotta listen, guys. Mania. That is the bipolar type. Now, if the individual has never experienced any mania, you will diagnose them with schizoaffective depressive type. Yes, depressive type is no mania. One of my supervisees asked an amazing question. I'm gonna give you a shout out. You know who you are. You're kind of shy. You might not want me to say your name, but I'm gonna go ahead and give you a shout out because you had me thinking about this, and you're the reason I did this training today. She asked in supervision when we met just a few days ago, she said, well, if someone has hypomania, would you give them bipolar type or would you give them depressive type? Dang, that's a good question. So I had to pull out the DSM, do some research, kind of pull out the, my thinking cap because I had never had anyone ask me that. But in my research, it shows that there's only 2 specifiers. You have the bipolar type and they have to have experienced mania, and then for depressive type, no mania. So it made it plain and simple to me that we would have to give a person, even if they have hypomania symptoms, the depressive type. It feels a little weird and it might feel a little abnormal to do that because you're like, this person has experienced mania, they're not depressive, but it's not full-blown manic, it's hypomanic. So that's how we have to think about it. All right, but go ahead, follow along. So I hope you got your little note sheet and you wrote it down. So far we went over schizophrenia, we went schizoaffective, and schizoaffective has the 2 types. So if it's bipolar type, they have mania. If it's depressive type, they have no mania. You got me? Cool. Let's move on to the next one. Bipolar 1 and bipolar 2. This one right here, I always explain, if you've worked with me in my coaching sessions, or if you're somebody that I supervise, you know the easiest way for me to memorize this, because yes, this is a lot of information I have to remember in my brain as well. So bipolar 1 has one more symptom than bipolar 2. That's kind of how I memorize it. Bipolar 1, that one more symptom is what? Mania. Yes, that mania separates bipolar 1 from bipolar 2. So let's talk about bipolar 1. Bipolar 1, you have to have at least one manic episode. And normally a manic episode means, you've had these symptoms of mania for 7 days or more, or you've likely been hospitalized. Not you, but the individual that has this diagnosis. It may also include some depressive episodes, but it's not required. Someone can have bipolar 1 and not have any type of depressive episode. But it may include some psychosis, but that's only during the mood episode. If somebody's having a mood episode will be what? Yes, some of those depressive symptoms and things of that nature. They may also experience some psychosis there for bipolar 1. Hear me out, that's bipolar 1. So if you got your little note card, hopefully you wrote that down. Just to recap, at least one manic episode. Manic is defined as 7 days or more of these symptoms or hospitalization. They may include depressive symptoms, but it's not required. And it may include psychosis, but only during a mood episode. Now think about this, bipolar 2. Bipolar 2, you have to have at least one hypomanic episode. That means 4 days or more of certain type of symptoms, and that is the hypomania. Normally bipolar 2, they're not hospitalized. It's a little bit milder than bipolar 1. And they also have at least one major depressive episode. No history of ever having a full manic episode. So this makes it a little bit easier, guys. So bipolar 2, one hypomanic episode, one major depressive episode, no manic episode. That's what you need to think about. And I'm gonna go ahead and move on because I don't want to add too much more fuel to the fire. All right, so let's talk about major depressive disorder and psychotic features. So yes, somebody can have major depressive disorder with some psychotic features. So basically the person has to meet the full criteria of major depressive disorder, and the psychotic features present only during depressive episodes. So a lot of times when people have major depressive disorder, that doesn't mean they're always depressed, like every waking moment, but they do struggle with depression a great ordeal. So in this case, if someone is having depressive episodes and they start having psychotic features during that time, they would have major depressive disorder with psychotic features. So there are two types. You can have mood congruent or mood incongruent. And I'm not gonna go all deep into that stuff because, to be honest, guys, it gets a little bit confusing, and I don't really use it even in, my private practice and seeing clients and so forth. Major depressive disorder is pretty much enough. With psychotic features is even better. But when you start getting into the mood congruent and mood incongruent, you want to really be deep diving into your DSM and really be working with clients on a consistent basis and have that skill set to do it. Because I don't believe in overly diagnosing and putting stuff in there if you're not really comfortable or sure or certain or sure of what it means, because this is somebody's life that you're impacting. So really be mindful when you start getting to all the types and everything. It's okay to do it. So I don't want you to hear that I'm saying not to, but just make sure you know what you're doing before you do so. All right. And another one, there's no psychosis outside of the depressive episode. So with major depressive disorder, remember that's one disorder, but today we're talking about major depressive disorder with psychotic features. And if they have the psychotic features, that means they have all the symptoms of major depressive disorder, but when they are depressed, they're having those psychotic features. So if they don't have any psychosis, or if they have psychosis, it has to take place during the depressive episodes. That is how they get major depressive disorder with psychotic features. So remember, there's no psychosis outside of depressive episode. Yes. I know this is a lot, guys, so that's why I'm hoping you're taking notes and following. But you guys have been working with me long enough to know that I'm going to share my screen and I'm going to go ahead and break it down and make it a little simplified so you can kind of see it in real life and have all these things that we went over and tell you certain things that kind of help you memorize it. So I will recap, but I want you to hear this and understand it and start thinking about it as it pertains to clients you've worked with or a question you might see on the exam. The next one we're going to talk about is brief psychotic and schizophreniform. I love that schizophreniform. Maybe it's just the schizophreniform. It's just something about that diagnosis, which a lot of people just don't even know what it means or like to say it because it looks weird. So with brief psychotic, you have 1 day, but at least less than a month. Let's say 1 day to 30 days, someone has brief psychotic disorder. They will be defined because they have a sudden onset. Then they fully go back to their baseline. So let me recap. Someone with brief psychotic disorder, say someone you met with them and you're like, whoa, things are a little different, a little off. They have these psychosis or these psychotic symptoms, but maybe it's been 3 weeks or 2 weeks or 4 4 weeks or whatever it is. But after that month, they go back to their full baseline and they no longer show symptoms of that psychosis. That would be a brief psychotic disorder because it was 30 days or less. Now, schizophreniform, that's the tricky one. And a lot of people don't use this or define people with having this, but sometimes people have these symptoms of schizophrenia, but they don't last over 6 months to even be defined as schizophrenia. So schizophreniform is for at least a month, but less than 6 months. At least a month, but less than 6 months. So the symptoms for schizophreniform are the exact same as schizophrenia. Yes, it's schizophrenia twin, basically. It's just one came out before the other. I don't know if that makes sense. But anyways, and schizophrenia are pretty much identical, except schizophreniform is a little younger. 6 months or less, you're looking at schizophreniform. But if it's 1 month or less, you're looking at brief psychotic. Hopefully you get what I'm throwing down. So when you see these two diagnoses, sometimes they're often provisional because you're like, I've only been working with this client for 3 months, or this person came to the hospital to be evaluated and they've only had these symptoms for 2 months. You can't really give them schizophrenia because they're showing having these symptoms for a longer period of time, but not long enough for you to diagnose them with the full-fledged schizophrenia. So a lot of times schizophreniform and brief psychotic are just provisional diagnoses, meaning this is kind of what they have in the interim until they really figure it out and hash out what they have. Hey guys, let's stop by to tell you this. You do not have to win alone. Absolutely not. People in the community are winning each and every day. The proof is in the pudding. Go in the community, it's free. We're throwing down test questions, case studies, the FNBM method, all the details and everything you need so you can succeed. Click the link in the bio and join. You don't need to do this alone. See you soon. Let's move on. We're going to talk about delusional and substance-induced disorders, or should I say delusional disorders. Now, in order to have this diagnosis, you have to have at least one or more delusion lasting for 1 month or more. No significant functional impairment outside of the delusion. So that's it. You just have delusions. And no hallucinations or bizarre behavior. Yes. So that's pretty much what it looks like when someone's diagnosed with delusional disorder. But in order for someone to have it, just remember that. One delusion lasting 1 month or more. No other significant impairments, and hallucinations, bizarre behavior, all that stuff does not have to be present, and the person has delusional disorder. Now, if it's substance-induced psychotic disorder, normally the psychotic symptoms happen during or shortly after substance withdrawal or substance intoxication. So meaning this individual has used or have tried or experimented with a certain type of drug, and as a result they're having psychotic features, and it shows up pretty suddenly or pretty much while they're experiencing this drug or right after they use this drug. So that is something you have to be mindful of. That is the substance-induced psychotic disorder, and I'm using substance and drug interchangeably, but that's basically what it means. So with psychotic symptoms taking place, but it's only after they've used the substance or the drug and they're either withdrawing from it or they're currently intoxicated. So that's kind of the difference between someone having a substance-induced psychotic disorder versus like a delusional disorder or schizophrenia or anything like that. Hopefully that makes sense. And some substances would be like alcohol, cannabis, stimulants, hallucinations, all that kind of stuff is some of the substances that you're likely to see. All right, so what I'm gonna do now is pause, get a drink of water, and then I'm going to share my screen and we're going to break it down what I just went over. So stay with me. All right, your girl is back. Yes, you didn't even know I left. But anyways, I just had to tell you guys that I left so you know. Let's go through this comparison chart because we went over a lot. And I know some of you are writing your notes and you're like, oh, this is just too much. I don't know what. So I'm going to go ahead and just use this comparison chart because it makes it a little bit easier to kind of see what I was saying and kind of visualize it for yourself. And you can go ahead and take a picture of this because if you're not in my community, or better yet, if you're not in my course, I likely am not going to share this. This is something that is located in my course. I kind of do a lot of the YouTube videos and kind of put them all in there with the notes and the content. So this is a comparison chart for psychosis. So I'm going to go ahead and share the screen with you guys. So let's talk about all the diagnoses on the left-hand side. Then you have the mood symptoms, psychotic symptoms, the timeline, and unique features. So real quick, schizophrenia, no prominent mood symptoms. Yes, there is psychosis, and remember, you have to have it for at least 6 months or more. And negative symptoms are often present. Schizoaffective disorder, you have the mania and the depression, the mania or the depression, that lets you know those are the types of moods they could experience. And yes, 2 weeks or more, they can go without some mood changes. So that is the psychotic symptom. 2+ weeks without mood. The time frame definitely varies for schizoaffective disorder, and it's a combo basically of schizophrenia and mood. So I always tell people, if you have somebody that's schizophrenic and they show some symptoms of mood instability or some things just going on mood-wise, then you're likely considering and looking into schizoaffective. All right, bipolar 1, yes, that mania. Bipolar 2, no mania. So this is pretty much what it looks like. And yes, you can have psychotic features with bipolar 1. Mania is the anchor in the diagnosis of bipolar 1. Major depressive disorder with psychosis, depression only. Yes, there is some mood congruency. And the timeline is at least 2 weeks, and psychosis is normally tied to mood only. So if someone has major depressive disorder with psychosis, it's tied to the mood only. That is why they don't just have psychosis without having that mood symptom. So that is a unique feature of it. And then delusional disorder, you remember, you don't have to have any mood symptoms here, delusions only. And you don't even have to have any other, major symptoms that you see in some of these other psychotic disorders. All right, so I hope this comparison chart was hella helpful and you're able to learn from it and get what you need. And we're going to go over some case vignettes, but these cases are a little bit different. I'm just giving you a vignette explaining something and then telling you what best fits so you can see the answer on the screen, but it just helps you see it a little bit clearer. So this client has auditory hallucinations, disorganized speech, and reports God is sending messages through the TV. She has no history of mood disturbance. So basically the best fit here would be schizophrenia. Why? There are no mood symptoms and the symptoms are present for at least 6 months. So that is pretty much why we would kind of look at it and judge. Now, again, when I say the symptoms are present for at least 6 months, these are the things that you want to kind of look at and consider in the scenario. Normally, if they want you to guess or gauge whether it's schizophrenia, schizoaffective, well, not schizoaffective, but schizophrenia, schizophreniform, brief psychotic, things like that, they're going to give you the duration. If not, you kind of have to just roll with the information that's given to you. So hallucinations, disorganized speech, all of these things align. Remember, you have to have that criteria A, B, and C. You have to have at least 2 out of those top 3. And that's it, the auditory hallucinations and the disorganized speech. So the person already has the top criteria needed for schizophrenia, and we don't see anything going on with the mood. The only thing that this vignette is missing is the time frame. So if this individual shared or was reported that they had these symptoms for 6 months or more, then we're definitely going with schizophrenia. Now, if they said that the person's symptoms were present for 30 days or for the last 2 weeks, then we know we're going with brief psychotic disorder. Yes. And if it isn't going on between 1 month and less than 6 months, schizophreniform. Yes. So you want to think about that. They're all pretty much the same. So you want to see schizophreniform, schizophrenia, and brief psychotic are pretty much identical. It's just the duration. So a lot of times in a test question, we're leaning more towards schizophrenia because they likely will, provide that. But if the question only had, say, schizophrenia, bipolar 2, major depressive disorder, and anxiety, we're going to go with schizophrenia, even though it doesn't have that time frame. We just have to assume or not read too much into the question and just know that the major symptoms align with schizophrenia. I have to say that because I know a lot of us are so literal and we're just looking for everything, like, can't be that because of this. But I'm letting you know how it might present. All right, let's go on to vignette number 2. So the client has delusions. They have auditory hallucinations. And this one, how long? 3 months. Yes, I'm putting a duration in there, guys. He had a manic episode a month ago and depressive symptoms last year. He experienced hallucinations for 3 weeks without any mood symptom. The best fit? Schizoaffective disorder, bipolar type. Why? Because it meets all the criteria for schizophrenia, like we just talked about. It meets all the criteria for schizophrenia. They have the mood episodes, and it's been 2 weeks of psychosis without any mood symptoms. Now, again, this says the delusions and auditory hallucinations for 3 months. They also had a manic episode a month ago and depressive symptoms last year. So yes, it's not saying for the last 6 months or the last this, but this person has been having experiences and symptoms for a long time. So with that, we want to be mindful of the diagnosis that we provide them because now these symptoms have been taking place for a year or more. So we're leaning towards the schizoaffective disorder bipolar type. And again, you can wash it out. You might have some other options there that might fit and might meet the criteria even more. I can't think of any, but if you think of some, throw it in the chat section. I love when you guys challenge me and come up with some things or see something differently. All right, let's go through the clinical vignette number 3. All right, so client had a week-long episode of decreased sleep, high energy, impulsive spending, and believes that she's a prophet. After 10 days, the symptoms remit with treatment. So the symptoms got better, but it was after 10 whole days. So we know it's been over 7 days that they've had these symptoms. symptoms. And clearly this person is having a what? Yes, a manic state symptoms. Manic phase, what I'll say. But they have no depressive history. So in this case, we're going to say bipolar 1. That mania just screams at us. It's just yelling, I'm manic, I'm manic, I'm manic, especially with the decreased sleep, the high energy, the spending, and all that kind of stuff. So yes, that is it. We're going to go with bipolar 1. Here's another one. Client has persistent depressive symptoms. I don't want to confuse you guys with the persistent depressive disorder, but just follow the vignette. The client has persistent depressive symptoms, and reports hearing a voice telling her she's worthless. Psychosis disappears when the mood improves. That's the key. Remember, we shared with MDD with psychotic features that psychosis has to take place when they are having a depressive symptom. So that is why we're looking at major depressive disorder. Absolutely. All right, vignette number 5. The client has had fixed beliefs for 3 months that his neighbor is spying on him using a hidden drone. Okay, never mind. So, but there are no hallucinations, no bizarre behavior, and he works full time with no impairments. So remember what I shared with you guys earlier, delusional disorder, all you need to do is have that delusion, and it has to last for at least 1 month, but you don't have to have no other type of impairment or psychosis. So this is a clear indication of a client presents with visual hallucinations and paranoid delusions after using LSD. Ooh, LSD is a sup or a drug. So the symptoms start the night of use and resolve within a few days. Obviously, it's substance-induced psychotic disorder. We talked about that. When someone starts experiencing these psychotic symptoms during the time they're using the substance or when they're withdrawing from the substance. So as you can see, he returned to normal after a few days. So clearly we know that the symptoms were tied to his substance use. Are you studying for the LCSW or LMSW exam? Don't waste time on the wrong prep. Try my test prep program for free with a full module that gives you the real strategies, the real practice, and real results. Plus, you get access to my exclusive test prep community where you'll find support, study material, and accountability. No risk, no stress, just results. Click the link in the bio so you can get ready to win with the winning team. All right, here's another one. Client was hospitalized with hallucinations, disorganized behavior, and bizarre delusions that had lasted for 3 weeks. I'm throwing it in there, guys. Yes, 3 weeks. So it's less than 30 days. They have no previous history and returns to baseline quickly. Yes, brief psychotic disorders, because it is brief psychotic disorder, because it has been less than a month and it's sudden onset and then boom, back to normal. All right, so I hope this was hella helpful. And as you can see, I have given you some vignettes that are a little different. A lot of times we give you these questions like here, and then we ask you to kind of answer it. So I am going to do one of those breakdowns for you today because you know my FNBM method is the game changer, and people are just passing by the, I want to say hundreds, but definitely the high dozens right now, because this is a fairly new method and breakdown. So I do want you guys to understand that it's very helpful. But again, like any system or anything you choose to utilize, you must have buy-in. You must truly believe that it can help you get to the next point, or that it makes sense to you and you can apply it. A lot of times we hear things and we see it and like, oh, I'm gonna do that, I'm gonna use that too. It might not make sense to you. So yes, during all these, trainings and YouTube videos, and if you're in my coaching community and stuff, I'm going to break down the FNBM method, because to me, it's a game changer and it's really helping. And I get people who message and email me and text me all the time. I'm going to see if my editor can throw one of those up there on the screen so you can see it. But yes, you hear people using something and it's working for them, but again, they put in the work. So it's kind of like, I'm just going to throw basketball out there. I only know one basketball player for real, because I'm not really into sports. I'm just going to say LeBron. Well, no, I know Stephen Curry. Okay. But anyways, I'm going to stick with LeBron. So I'm sure LeBron has practiced something over and over and over and over and over again before he decided to show up in the game and just put it to work. He practices during practice. So that is what you guys need to do. You can't hear something, see something, and say, oh, I'm going to use it, and never practice. So at the bare minimum, when people are in my coaching program or in my course, or say they're just in the community, the free community, and they're getting game and they're messaging me and asking me stuff about, what I think about this or where they are in their process. And some of them are using all types of test prep programs. Again, I don't care about what program you use as long as it works for you. So I've had people to come to me and they talk about a specific program. They're not sponsoring me, so I'm not mentioning them. But anyways, they'll tell me a program that they're doing, and they'll tell me, oh, I'm getting all these questions right. I'm doing this, I'm doing that. I've taken all the exams. Maybe they've been in the program for 2-3 years and they've been using the same system. I was sharing with someone the other day, yes, you're getting them right and you're working, so the content is there, but maybe you're starting to memorize the questions and you're starting to understand and know what they are. So I haven't shared this, but I do have an affiliate with Pocket Prep, which most people already have it when they come to me. But if you have not purchased Pocket Prep, please hit the link in the bio, check them out, because they have 1,000 questions that'll help you prepare for this exam. I even go in there and just test my knowledge every now and then. They are not, I have to clarify, they're not ASWB style questions, which everybody wants, but a question is a question, guys. You can learn from any type of question as long as it's providing the content and the knowledge that you need. So I do just want to share that, because I get a lot of people say, I want the ASWB type style question. And the reality of it is, none of us work for ASWB. So we're doing our research and we're putting together questions that emulate, stimulate, or seem very similar or familiar to test taker examiners. However, none of us are in the head of the ASWB and know exactly what type of question and style they're going to put on the test. We can only get close to it. And that is through research and trial and error and all that stuff. So I just want to share with you guys, at the bare minimum, take a full-fledged test. A lot of people are jumping in and they practicing, but before the game day, like before you take the exam, do a full 170 question exam. I have them in my community. You can purchase one there. If I go into the learning tab, I have one for the LMSWs, one for the LCSWs. I am in the process of creating more, because some people might want different ones. And pretty much every test prep program has them, where you can purchase them on the side or you can have them in the course. But I'm just giving it to people who've been all coursed out and you just need other questions that might not be similar to the course that you're taking, to kind of change it up a little bit. So just give that some thought. But I'm gonna jump into this question because this video is getting long and I already know my people's attention span. I watch the analytics, and sometimes I lose y'all at 6 minutes, 8 minutes, 10 minutes. And I'm like, well, damn, how they gonna sit for 4 hours? But anyways, all right, here's a question. A client presents with hallucinations and a 4-day period of elevated mood. Hallucinations, 4-day period, elevated mood. What should the social worker consider first? A, bipolar 1, B, schizoaffective disorder, C, bipolar 2. Now, this is a really challenging one. Some of you might know the answer right off rip, but think about it. They have hallucinations and it's been 4 days of an elevated mood. So let's break that down. We're going to use the FMBM method to just break it all down. First, we need to do a full diagnostic examination, or biopsychosocial, whatever you want to call it. That's pretty much what we're going to do first. But if the individual has told us that they have 4 days of hypomania, so they're not mania, because it hasn't been 7 days or more. I don't hear about any hospitalization, none of that stuff. So we're going to rule out bipolar 1, because bipolar 1, you have to have what? Yes, mania. And this person's only had a 4-day period of elevated mood. So we're looking at hypomania. Now, the person has hallucinations plus the hypomania. So we want to kind of consider schizophrenia or schizoaffective, but not the bipolar type. Why? Bipolar type, they must have mania. Yes, I said that early in the presentation. Hopefully you guys remember that. So this diagnosis will likely be schizoaffective, depressive type, or schizophrenia, just depending on the duration and how long a period of time that the person has had these mood symptoms and so forth. So for this question, when it says, what should the person consider first? We're going to consider schizoaffective disorder, because we see the hallucinations. They also have the elevated mood, but that's the only thing we can tie it to, because they have that mood and that psychotic thing going on. So this is something we're going to look at. Is it definitely this answer? No, we'll need a little bit more detail. But again, sometimes the test just gives us a little bit of meat and we got to figure out what we're going to do with it. We got to figure out how we're going to digest it and what we're going to do, versus saying, oh my God, they gave me the meat but no gravy. I need to go back and get the gravy. No, you don't go back and add anything to the question. You just keep what you got and make it work. All right. So final takeaways: use timing, mood, psychosis, relationship, and the functioning of the individual as a guide when you're diagnosing them. Always ask, are the symptoms happening together or are they happening separate? Because some of these symptoms that we went over, it happens after. Like the person has this symptom, then this happens, or they have this, but not when this is taking place. So you got to be mindful of that. That'll also help you understand which diagnosis is which. Now, psychotic symptoms only during mood, you're looking at some type of mood disorder. You get it? Now, psychosis on its own, you're looking more of a psychotic disorder. So again, guys, join the community. You'll get the free printable cheat sheet. You'll get more practice questions with the first, next, best, most. This question right here that I'm sharing with you guys, there's a cheat sheet that I have created for this, but it's likely in my course. But again, you guys took all type of pictures and screenshots and stuff. And if you join the community, you could at least at the bare minimum get the first, next, best, most cheat sheet. Will help direct your path and help you understand where to go to, or where to go when you're taking the exam. All right. Follow me, guys. LCSWVIBES, TikTok, Instagram, YouTube, whatever your social media platform of choice is. But of course, you know, my favorite is the tube, baby. Yes, because I get to do these long form videos and really educate y'all. All right. Thanks for staying in. Thanks for tuning in. Please make sure you like, share, subscribe. If you made it this far, you stuck with me. So just please, at the bare minimum, like the video. I have to share that with you guys because you already know that helps the algorithm. People are like, I never knew you existed. I am the new kid on the block, and I'm okay with that because you know what? I'm here to stay. I'm taking over the block. All right. Great chatting with you guys. Hope this was helpful. And just because this is probably one of my longest videos, I'm probably going to throw some type of cheat sheet out. So just join the community and see what I got for you. Be blessed.